And I'm going to start today's presentation. The presentation was actually transplantation in sensitized patients. What I have been feeling of late in personally, many of my patients who are coming to be crossmatch positive or DSA positive, and I'm encountering a lot of patients where we have to use this desensitization protocol. So in those cases, personally, I feel we need to have some kind of desensitization protocol, and this is increasingly a situation when most of us are coming across this problem in day-to-day life. And most centers, earlier there used to be 1 or 2 centers where renal transplantation used to take place. Now so many centers are there where transplantation is taking place. Therefore, we all need to have some understanding about this area, how to go for desensitization in sensitized patients. But before we go for desensitization, we actually need to know the physiology or the basics behind a cross match so that we can prepare a person for desensitization. That is why I have decided that I will present this topic. It is a very extensive topic, maybe in 2 parts or maybe in 3 parts. The very first part of this presentation would be understanding cross-match testing in organ transplantation, a general outline for the transplant nephrologist. Now, most of us are not immunologists. Most of us are not corely involved with our lab. We are not into genetics, so we do not know very specifically where a test is taking place. Our tests are most of the other than Apollo Hospital in Bhubaneswar, our tests are outsourced, so the patients are going and getting the tests done in Mumbai. Unlike our centers, when I was in SDPJ, we had our in-house department, so we can just walk into the department of genetics. Our nephrology department later on had a immunology lab, so that the cross-matching and everything would be done inside. We can have a first-hand experience of what is taking place inside the lab. But right now, it's not possible for most of us. So we need to have an understanding of the cross-match, very basics, because even it will not be possible even in this platform to have a very extensive understanding about. We'll go and look into the very basics of cross-match in organ transplantation, a very general outline. Now, what is cross-matching? Cross-matching is basically developed to identify recipients who are likely to develop acute vascular rejection from the graft of a given donor. So anytime a graft is put into the body of a recipient, the body tries to reject it. But hyperacute rejection is a result of preformed antibodies to one or more of human leukocyte antigens from the donor. This is also referred to as donor-specific antibodies. These preformed antibodies are referred to as donor-specific antibodies. Donor-specific antibodies can be formed as a result of previous exposure to this HLA, or the donor gets exposed to either recipient HLA or similar HLA. The recipient gets exposed to these donor HLAs or some other HLAs, giving rise to formation of antibodies in the body of the recipient even before the act of transplantation. Therefore, there is some kind of preformed antibodies are there. What can be the primary sources of formation of anti-HLA antibodies? It could be pregnancy, blood transfusion, or previous transplantation. Now, developing anti-HLA antibodies via microbial exposure is also another option. And exposure of women during pregnancy to their partner's HLA is, of all these criteria, is one of the most relevant, because you are not even suspecting in these circumstances. The patient has not had a blood transfusion, the patient has not had a previous renal transplantation, but merely which is very common in the women of a reproductive age group, women who have had pregnancy, and especially if they have got multiple pregnancies, then there is always a chance that they might have got exposed to the patient's or the partner's HLA. Apart from what's mentioned, hyperacute rejection may occur in blood group incompatible transplantation without desensitization. If a blood group incompatible transplantation takes place without desensitization, of course, there is hyperacute rejection. Can occur immediately upon reperfusion of the donor kidney, and hyperacute rejection is not desirable. Cross-matching helps predict. Hence, it is, of course, something which is not desirable, and cross-matching helps predict and hence prevent this. Now, what are preformed antibodies and how do they cause the rejection? Preformed antibodies cause rejection by binding to the HLA antigens which are expressed on the endothelium of the vessels in the transplanted kidney. Now, let me repeat it. There are HLA antigens which are expressed on the endothelium of the vessels in the transplanted kidney. And preformed antibodies act against those antigens. There is a that results in activation of the complement cascade. That's where things go wrong. That results in activation of the complement cascade with resultant thrombosis and infarction. Once the graft is thrombosed and infarcted, then we lose the graft. Therefore, once this takes place, there is a catastrophic outcome and we almost lose the graft, and sometimes it requires to remove the graft under these circumstances. Therefore, we must ensure before the act of transplantation that the whole process of transplantation is safe and ensure that there are no preformed HLA antibodies. There are different types of crossmatch that are available. One is CDC crossmatch, one is flow cytometry crossmatch, and the third one is virtual crossmatch. Now, what most of us will encounter in our everyday practice before going for transplantation is, of course, we always go for the CDC crossmatch. The other cross matches are of latest thing, but what we normally and always have been doing is the CDC crossmatch. Flow cytometry crossmatch and virtual crossmatch are not something we are regularly doing, and of late we have started doing. Some of the centers have started, but the technology is available. We need to understand so that we can implement it. We need to understand the science behind, and we need to understand where and how appropriately we can incorporate this so that we can really use them to the best of our benefit, to the best of our knowledge. Now, CDC crossmatch. A crossmatch which involves placing. Now, what is a crossmatch? We are not doing the test in our own lab, so we must understand the recipient serum is mixed or is made to mix with the donor lymphocytes. It's a process which involves placing recipient serum which potentially contains donor-specific anti-HLA antibodies to the donor's lymphocytes, which definitely contains the HLA antigens. If there is a cytotoxic reaction, which seems which gives the test as a positive test, then there is presence of donor-specific antibodies. Obviously, we do not want a positive test. So what we would actually need to have is a negative test. But if there is a positive test, it indicates the presence of donor-specific antibodies. Now, this is an example of a case of a 44-year-old woman. These are random cases which will give us an idea about how to proceed in each case. This is a 44-year-old woman with an end-stage kidney failure with reflux nephropathy, and they are going for a husband as the donor and the same blood group. Of course, husband, we are not dealing with ABO incompatible things today. There will be entirely a different session if at all we have. So in this case, the HLA matching in between the patient and the donor is 0. There is no HLA matching. There is total 0/6 matching. They have a CDC crossmatch which is performed as part of their initial assessment, which shows a positive result for both T and B cell crossmatch. This is how the things displayed here. These are the HLA ABDR, which is the HLA alleles or HLA locus on which we normally do the testing, and this is the CDC crossmatch, CDC T, and both positive for T cell and B cells. Now, what is interesting is that, is it safe to proceed? No, obviously, if the crossmatch is positive, it's not safe to proceed in light of this crossmatch. But are we clear enough? Are we sure enough? No, we need further clarification to better understand the result of these positive results. What could be the possible caveats? What could be the possible things? Is it a false positive result? Or there may be autoantibodies present in the recipient serum. Autoantibodies are generally IgM rather than IgG. And remember, IgM antibodies have no pathological significance in transplantation. They may be very important in other infection diagnosis, but in the case of transplantation, IgM antibodies have no significance. So what do we do to first rule out if autoantibodies are responsible for the result of the crossmatch? We perform an auto crossmatch. Second, the original crossmatch should be repeated with the addition of the agent dithiothiotol, that is DDT. For simplification of utterance, I will not utter the complicated term dithiothiotol. It's very difficult to pronounce it. So DDT. DDT reduces the disulfide bonds in the IgM, thereby preventing IgM antibodies from generating a positive result. DDT essentially what it does is it doesn't allow the IgM to give a positive result. So if you add DDT, then if the result is positive, then mostly it is because of the pathological IgG antibodies, not because of IgM antibodies. Now, IgM antibodies are regarded as I just said, it's not of pathological significance. So a repeat crossmatch with DDT is negative, then it may be. Now, if the repeat crossmatch with DDT is negative, then you can say that the positive result may have been a false positive result because of the presence of IgM antibodies. So after adding DDT, if it is negative, then it may be safe to proceed with the transplant. So we must be very sure if DDT has been added. In many of our reports, if you can note, in the CDC Crossmatch report, they mentioned that DDT has been added. This is once again how it turns out. The original Crossmatch CDC was negative. Crossmatch was with phosphate buffered saline. Now, phosphate buffered saline is added just to ensure that whether DDT causes the negativity because of dilution or because of its effect on the IgM. Try to understand. DDT, by addition of any other agent, it can dilute the antibodies also. But we don't need any effect of the dilution. So if the crossmatch is positive after adding phosphate buffered saline, then DDT is not the culprit here. Anyway, I won't complicate things over further. Or now in this case, auto crossmatch was found to be positive, and after addition of DDT, the crossmatch was negative. These results suggest that the reaction of the recipient to the donor is on the basis of autoantibodies. Now, when interpreting crossmatches with addition of DDT, check the reaction in the wells to which a control agent has been added, usually phosphate buffered saline. This is just something I have repeated, so I will proceed further. This is the cross-matching technique, CDC cross-matching technique. As I said, in a CDC cross-match, what happens? There are the recipient serum. This is recipient serum, which may potentially contain donor-specific anti-HLA antibodies. And these are the donor lymphocytes. And these are complement. A recipient serum potentially containing donor-specific anti-HLA antibodies is added to the T or B lymphocytes along with the complement. Complement-dependent cytotoxicity cross-matching was something which was pioneered by Terasaki and the colleagues in 1960s. What it essentially does is it seeks to identify clinically significant anti-HLA antibodies if they are present in the recipient serum, and which can give rise to the reaction against the donor lymphocytes. Now, if the donor-specific antibodies are present, as mentioned here, then these two will of course bind, and after binding, a complement is added, and what it gives rise to is a complement cascade will be activated. A classical complement cascade will be activated that will give rise to basically a positive result. This is how. Now, if a positive result is there, the proportion of light cells is assessed. The crossmatch is graded as being weakly positive, moderately, or strongly positive. The readout of the test is the percentage of dead cells relative to the live cells as determined by microscopy. Normally, you must have seen that in most of the tests, what is seen is the 20% label. So if the percentage or the levels are shown as 2, 4, 6 on the increasing basis of dilution, On the basis of this, a score of 2 is positive at a low level, consistent with approximately 20% lysis, which is generally taken as the cutoff value. 20% is generally taken as the cutoff value, beyond which we do not perform the transplant. We consider the test as positive. Below 20%, we think it's safe enough to proceed with the transplant. There can be other methods, similarly like going for, what I would say is that going for a dilution, going for serial dilutions and all those things, but again, I will not go into further details. You just take a look at this picture once again, and then I'll proceed on to the next slide. Okay, is everyone clear about it? Once again, is everyone able to follow me? Am I audible to everyone?
Yeah, sir, you're audible. I think people are muted, but I think
fine. So we will proceed on to the next slide. The next slide, what CDC Crossmatch Considerations and Interpretations. It can be enhanced by addition of anti-human globulin. Now there is a donor-specific antibody and lymphocytes. They together bind. To that we add some more anti-human globulins. When it is possible to have a negative crossmatch even in the presence of donor-specific antibodies. Situations where donor-specific antibody, if the donor-specific antibody is of a type that does not activate complement, or when the antigen for which the antibody specific is expressed only at low levels. So in these cases, if we add an anti-human globulin, this may make the reaction presentable even when low levels of antibodies are present. And what it actually does is, it actually causes, it opens up, this technique actually increases the sensitivity of the CDC crossmatch as a result of multiple AHG molecules or anti-human globulin molecules binding to each donor-specific antibody attached to the donor cells. Already donor-specific antibodies are attached to the donor cells to which this anti-human globulin is added. It amplifies the total number of Fc receptors available for interaction with the complement component. Remember our days reading from about immunoglobulins and microbiology, the classical picture where Fc receptors were there. In the picture of an immunoglobulin, it enhances the total number of Fc receptors, making the whole thing more presentable. Anyway, what is again another important and interesting thing is the different times at which an individual serum is collected. Maybe we do the transplant, we do the first CDC crossmatch in the month of May, and we do the transplant in the month of December. By that time, the first time the crossmatch may be negative, and the second time the crossmatch might turn out to be positive, or first time the crossmatch might be positive, second time it may turn out to be negative, because the most reactive serum is generally called the peak serum. The serum at which we collect is very important. The timing at which we collect is very important. May have been collected several years earlier with the current serum showing quite, and in between the patient might get exposed, might get sensitized because of a blood transfusion or some other pregnancy or other factors which expose the patient to risk. So these are things which can either turn a crossmatch positive, or these are things which can actually turn a CDC crossmatch negative. Moving on to, having said the first and the most common method of cross-matching, we will have a brief look into the basic immunology of cross-match. We all know the whole story of cross-match starts with matching of anti-HLA antibodies. Now, what are HLA? HLA is basically divided, is human leukocyte antigen, which is found on chromosome 6 that we know from our pathology, microbiology, and physiology days. Class 1, which are A, B, C, molecules are expressed in all nucleated cells. Class 1 is presented in all nucleated cells, and class 2 molecules are HLA, DR, DP, and DQ, and they are expressed in antigen presenting cells such as dendritic cells, macrophages, and B cells. There are very important differences in HLA expression between T cells and B cells, which influence the interpretation of crossmatch. Note here, T cells do not constitutively, T cells actually do not constitutively express HLA class 2. So the result of T-cell crossmatch generally reflects antibodies to class 1 HLA and only. B cells, on the other hand, express both class 1 and class 2. So a positive B-cell crossmatch may be due to antibodies against HLA class 2 and class 1 or both. Hence, if the T-cell and B-cell crossmatch both are positive, if both are positive, the interpretation is that there may be single or multiple class 1 HLA antibodies or a mixture of class 1 and class 2 HLA antibodies. I'll come to it once again. The thing should be easily understood by all of you, and then I'll go to interpretation of individual cross matches. Now, what happens if a person has got both T cell and B cell negative? Fair enough, safe, go ahead with the transplantation. There are most likely no donor specific antibodies in the patient. So you can go ahead. But if both are positive, then there are class 1 antibodies present. Remember, class 1 is present on both T and B cells. So if T and B are positive, there could be significant class 1 antibodies present, or there could be class 1, class 2 multiple antibodies present. Now, if T is negative and B is positive, it's still a possibility. Donor specific antibody class 1 are not present, or class 1 are present in a very low level. Either class 2 are present or class 1 are present in a very low level, but it cannot be a significant class 1 presence. Significant anti-HLA antibodies against class 1 HLA antigens are not present. But if T is positive and B is negative, is it possible? No. If you find out a situation where T cell is positive and B cell is negative, it's most likely a technical error, possibly related to B cell bioavailability, and the test should be repeated. From here onwards, we will proceed on to what is the interpretation of a positive T-cell cross-match and what is the interpretation of a negative cross-match, or what is the interpretation of a positive T and positive B-cell cross-match. B-cell CDC cross-matching is not as predictive of a hyperacute rejection as that of a T-cell CDC cross-match, and there has been much controversy as to the role of this particular thing. I think I need to tell you about one more thing. Yes, paired with the information about, but if we want to deduce something out of our understanding from a cross-match, then B-cell cross-match in itself is not very predictive. As I told, if T-cell cross-match is negative and B-cell cross-match is positive, then it doesn't have a very significant information. Paired with information about presence of donor-specific antibodies determined by more specific means such as antigen-coated bits. So we need to have further tests to ascertain whether this has got any other significance, or if a B-cell crossmatch is positive and there are no detectable antibodies to class 1 or class 2 antigens, the result may be falsely positive, while a positive result in presence of detectable antibodies signifies that identified donor-specific antibodies may be functionally relevant in that it can activate the complement. So once again, I'm leaving you with this picture for a moment. Both negative, great. Both positive, there are antibodies. T negative, B positive, still a possibility. However, has to be interpreted with caution. And T positive, B negative is a technical error. Now coming to the next type of cross-match, that is flow cross-match. What is this? This is an evolved one. We add recipient serum to the donor lymphocyte just like earlier one, but here we incubate them with fluorescent labeled antibodies against human immunoglobulin. The fluorescent labeled antibody will bind to all the immunoglobulins in the recipient serum, and if a donor specific antibody in this serum then binds to the donor lymphocytes, it will be detectable by flow cytometry. So the same thing takes place. What we do is we label some antibodies with fluorescent dyes. Now the colorful fluorescent dyes will be displayed by flow cytometry. Flow cytometry is so this is just an example of a patient and donor pair where the cross match is showing. This is the HLA matching. This is not first of a, I think it matches almost 50% between the recipient and the donor. But again, the cross match being CDC negative and flow cytometry cross match positive. What could be the possibility? Why CDC is negative and why flow cross match is positive? Because it could be donor specific antibodies being in low level or they are not complement fixing. If complement fixing is not there, then of course CDC will not show anything. Now flow cross matching actually detects antibodies binding to donor lymphocytes and suggests an increasing likelihood of antibody mediated rejection. Flow cross matches are more sensitive for detecting donor specific antibodies compared with CDC cross matching. Hence, a negative CDC cross match suggests that the antibody is low or absence of complement is there. But positive T-cell cross match, there could be positive T-cell flow cross match suggests that there is a donor specific antibody to class 1 antigen, while a positive B-cell cross match may be due to the same class 1 antibody or due to that other antibodies directed either against class 1 or class 2. What could be some other relevant points? Now, if the patient was a cadaveric donor, we would not have gone for a flow cytometry. We don't have much time for that. Without further information, most clinicians would accept a CDC crossmatch being negative and go ahead, but they will have a challenge because the flow crossmatch in this case would have shown a positive result and the patient already has antibodies. So cadaveric transplant, of course, we have less time to proceed. So, but in a live donor setting, since we have more time to reflect on the immunological aspects of the pairing and potentially desensitize the recipient before transplantation, what it does is that it gives us some idea whether this patient requires some kind of desensitization before proceeding with the transplantation. Now, that is what I was saying. If we have a flow crossmatch positive with CDC negative, then we must evaluate for alternative options, risk to be assessed, and information from other antibody detection assays is to be done. And then if the positive flow crossmatch is positive because of a very low level of antibody, we may proceed, but we understand the risks with which we need to proceed, or we may go for Luminex testing, what I will be saying very next. The flow crossmatch technique, it's again, as I had mentioned in the beginning of the flow crossmatch slide, this is donor serum, this is recipient serum, potentially containing specific antibodies, donor lymphocytes, and fluorescent level antibodies against immunoglobulin G. So if donor specific antibodies, anti-HLA antibodies are present and they bind to the lymphocytes, these can bind the fluorescent labeled anti-human immunoglobulin, and this will be detectable by flow cytometry. The strength of the fluorescence can be measured and expressed at channel shifts above the control sample. That's it. Now, the next thing that is in our basket is a virtual cross-match. This is one more example where a 65-year-old person has got end-stage renal failure. He has had 3 blood transfusions in the past. His wife has been assessed as a possible donor, and the immunocompatibility or the test is here. Here, this is the HLA matching. This is the CDC crossmatch, negative, flow crossmatch, negative. Now, antibodies detected by Luminex testing shows that anti-HLA antibodies are present against A2, A23, and B13. So what is the relevance of these anti-HLA antibodies and how do we reach here? Things would have been fine otherwise, but for this thing. As you can notice, this thing is the culprit because the donor has this HLA. Now, if the recipient will have anti-HLA antibodies against this donor, then there will be a problem. there will be a problem because this will be a preformed antibody, and immediately there could be some kind of reaction after the transplantation process. So proceeding in this with this setting of a CDC and cross-match, as I said, is this because of this culprit antibody. Now, despite the lack of reaction and cross-matching, you missed this both in CDC cross-match, both in flow cross-match, but it was still there. That is why the relevance of a Luminex cross-match. How do we do it? Screening for anti-HLA antibodies using Luminex. If positive, the specificity of anti-HLA antibodies are defined, while outcomes of donor-specific antibody transplants are inferior to donor-negative transplants. A decision to proceed with donor-specific antibody positive CDC crossmatch negative transplant in a highly sensitized patients in some cases be in the patient's best interest. Sometimes, despite everything, if you give the benefit of a transplantation to the patient, either by desensitization or something, the patient still might have a better life as you would have only if he had survived on dialysis. Now, the virtual cross-match technique. Try to understand here. This is recipient serum. Now, why it is virtual? Now, we are all on virtual media here. We are not sitting in front of each other, but we are still connected. So that is what is virtual. Here we do not have the donor lymphocytes. What we do is we have synthetic bits. Synthetic bits are coated with HLA antigens. The recipient serum reacts to those synthetic bits. Recipient serum potentially containing anti-HLA antibodies is added to a mixture of synthetic bits. Each bit can be coated with a set of antigens, or each bit can be coated with a single antigen, in other words, single antigen bits. A unique dye signature specifies the identity of each bit. Now, virtual cross-matching is this. If refers to the comparison of anti-HLA antibodies of the recipient as defined by Luminex with the HLA of the donor. It gives a comparison with the donor, but the donor lymphocytes are not used. If there is donor-specific antibody present, this should represent a virtual cross-match. Antibodies are again defined as against class 1 or class 2. If anti-HLA antibodies are present, they will bind to the appropriate bit and a detection antibody. Now, once again, after this binding, there is always a detection antibody, like a policeman, which goes and detects, okay, which pairs are binding. This is detection antibody and some method by which we detect what pairs are bound together. The culprit pairs are actually cut, and we have a result by a dual beam laser, or one laser detects bound receptor dye, the other identifies the specific, but though technicalities are for the people who perform this test. For us, it is important to understand that profile of antibodies can thus be identified in the recipient and compared with the known HLA identity of any potential donor, allowing a prediction of the cross-match result. Now, interpretation of this result. Presence of antibodies that react with human leukocytes portends a worse long-term graft survival. There can be sometimes anti-HLA antibodies which are not exactly donor specific, but even in this case, if these antibodies are called as third-party antibodies, even in this case, this is a worse scenario than having no antibodies at all. And those with donor-specific antibodies have a worse graft survival than those with having third-party anti-HLA antibodies. The presence of donor-specific antibodies always suggests inferior graft survival compared with no donor-specific antibodies, even in the presence of a negative CDC crossmatch. Having donor-specific antibodies via virtual crossmatch has a prognostic significance. So what it does is removes false positives, confusion, rigging class of HLA binding to be eliminated, and presence of donor-specific antibodies detected by Luminex in the setting of a negative CDC crossmatch have a prognostic importance in graft survival and the rejection risk. We can be more specific in our understanding, and we can remove the biases. There is another type of cross-match. I will not go into the details of it. All the cross-matching techniques actually are focusing on donor-specific antibody, but we do not look at the T-cell related rejection and the risk of T-cell related rejection. The presence of sensitization of the cellular arm of the immune system can be assessed by cytokine assays such as ELISpots. These assays detect the number of recipient T cells producing cytokines such as interferon gamma when encountering donor presenting cells. And these assays are conducted in plates coated with capture antibody for cytokine interest. The mixed donor and recipient leukocytes are added to the plate and incubated. I'm not going to go into the details of it, but I'll try to find out more about it so that we can make ourselves acquainted, and if possible, it has got any practical significance or not. Coming to our last few slides, once again, summarizing things, cross-matching is of course a vital tool in assessing immune compatibility of a donor and recipient. A positive T-cell cross-match, a particular pairing should not proceed. Positive T-cell cross-match after removing all the biases, if it is definitely positive, then it's not safe to proceed. A desensitization protocol may allow such a transplant, but with an inferior outcome. The advent of flow crossmatch and Luminex has allowed detection of lower titers but potentially clinical relevant anti-HLA antibodies by approximately tenfold. Tried and trusted technique of CDC crossmatch continues to remain essential. It should be coupled with the determination of specificity by Luminex. Now CDC Luminex would be good enough. Flow cytometry may no longer have much significance. So the ideal future crossmatch will be highly sensitive in hiding donor-specific antibodies, and it provides an accurate prediction of the antibody. Having said that, I feel I've given you a brief idea about the different modes and modalities of crossmatch. In our next session, we will have, now if we have donor-specific antibodies, if a patient is sensitized, how to go for desensitization. I think I will need one or more sessions for that. But for this presentation, thank you all very much for a very patient listening. I think I have been as clear as possible in my deliberation, because this is a very extensive topic. We need to come back to it again and again. Being clinical persons, we need to have some understanding of the basics of immunogenicity or basics of the immune approach towards organ transplant.